starting right now. So good day, everyone. Welcome to the opening of our DCB Academy sessions in 2025-2026. This is the start of a new chapter. So it's an honor to begin with one of our important members of DCB Academy, Dr. Leo, and a distinguished interventional cardiologist who's going to be speaking about the role of DCB in peripheral arterial disease. So the floor is yours.
Thank you. There are not so many of us present here, so I'm gonna try to be as short as I can. As I said before, in Romania, we as cardiologists are also doing the peripheral part, including visceral arteries, limbs, and carotid arteries as well. But I'm not sure how many of you are familiar with peripheral artery disease, so I'm gonna be very short. In the last presentation, I showed you a case we did last year in our cath lab, and we discussed about giving some data on the use of DCB in peripheral artery disease. So I'm gonna be very brief in presenting two of the most important randomized clinical trials on DCB in peripheral artery disease, which use the impact DCB. The first one is about the use of DCBs in below the knee lesions. It was a prospective multi-center patient-blinded randomized trial, which used the paclitaxel DCB and compared it to a standard angioplasty for the treatment of infrapopliteal artery disease in patients with Rutherford class 4 to 6. It included almost 360 patients from 13 European sites, and the primary endpoint was represented by freedom from clinically driven target lesion revascularization, freedom from major amputation, and all-cause death. It is very important to understand that these are the most important things that we have to be very careful about when we are performing peripheral artery disease interventions. Primary, we have to avoid major amputation. The safety endpoint was a composite of all-cause death, major amputation, the target lesion revascularization, assessed through 60 months. As you can see, most of the data was, most of the baseline characteristics were similar between the patients. However, there was a slight increase in the number of previous target limb revascularization in the DCB group. And also the lesion was slightly shorter in this group. Through 60 months of follow-up, the treatment effect was followed, and we can see that there weren't any important differences between DCB and standard angioplasty in below-the-knee lesions. What's more important, it seemed that there were more patients with standard treatment that didn't require another target lesion revascularization. When we look at the different endpoints, we can see that there weren't any major differences between the two strategies. Also in major amputation, freedom from TLR, all-cause death, and freedom from all-cause death. So we already knew that in below-the-knee lesions, DCB doesn't outperform standard angioplasty. However, it's similar to it. But regarding the femoral-popliteal lesions, we already knew this is a bit old study from 2019. But we already knew that DCB outperformed PTA in femoral popliteal lesions. This is also a very important study using impact balloon, which enrolled 331 patients, randomized 2-to-1 ratio to impact DCB or PTA. The primary endpoints were similar to the ones that I described for the previous study. And we can see in this case that DCB treatment for this type of lesions outperforms normal angioplasty by 9.2% with a significant P. Regarding this major endpoint, it is very strange maybe that it was statistically significant in the non-diabetic subgroup when subgroup analysis was performed. As in the diabetic subgroup, the endpoints were very similar. We can see that all of these endpoints, the target lesion revascularization, clinically driven target lesion revascularization, was statistically significant since the first year, and it maintained this until 3 years. After that, the significance was lower. However, at 5 years, it approached statistically significant. At 5 years, the only statistically significant difference was the freedom from clinically driven TLR. Taking all this in consideration and the fact that all these studies, the older studies, were performed with paclitaxel coated balloon, in the last 5-6 years, a new kid on the block appeared, and this was the sirolimus PTA, represented by Magic Touch. Many physicians ask themselves if maybe using another drug or another formulation might improve the outcomes of angioplasty in peripheral artery disease. So this trial was performed and was published 2 or 3 years ago, and included 50 patients with from which 20 were with femoral popliteal lesions and 30 with below the knee lesions. And the primary endpoint was the clinically driven target lesion revascularization. So after 3 years of follow-up in the overall group, 84%, it was an observational study, so it wasn't a randomized trial. 84% of the patients were free from TLR, 86% free from major amputation, and the overall survival was 63.3%, while the ulcer-free status in remaining survivors with the intact limbs was 100%. Taking them on subgroups, we can see a big percentage of all primary endpoints in the patients with femoral popliteal lesions, as well as in those with below the knee lesions. And we should remember the results from the impact trials, which were similar but numerically lower than this one. So probably a major trial comparing the two strategies, the two devices, would be very interesting to see. However, it wasn't performed yet. Another question that kept busy the minds of physicians were if maybe using a lower dose of drug would improve the results, or maybe would worsen them, because many are afraid of distal embolization of the drug and low flow in the distal part of the artery. So to respond to this question, an important study was published in JACC Intervention in 2023, which compared low dose versus high dose of drug-coated balloon for femoral popliteal artery disease in the Prospect Monster study. It was a prospective multicenter non-randomized trial, which included 580 patients who underwent therapy, either with a DCB, which was either Ranger, which is from Boston Scientific and has 2 micrograms per millimeter, square millimeters, or high dose, which was Impact, having a dose of 3.5. This was the flow chart of the study, and in the end they did a propensity score matching, and from all the patients they had they remained with 358 patients with low dose DCB treatment and 163 with high dose DCB treatment, and the primary endpoint was 1 year primary patency. So we can see here that in this study, the perioperative outcomes, which included the impaired flow, bailout stenting, or any other perioperative complication, was similar. So the safety endpoint was pretty similar between the two groups. While in 15 months after therapy follow-up, the primary patency was also pretty similar. So lowering the dose didn't affect in any way the final outcome. Also, for the other primary endpoints, there weren't any significant differences. The last question that I wanted to address with this presentation is not the last one. I have another one, is the comparison between drug-coated balloon and drug-eluting stent for this type of lesions, because most of the studies are comparing DCB versus standard angioplasty. So last year in Circulation, this study included, this retrospective single center observational study included almost 540 patients with femoral-popliteal lesions, and they use different DCBs, primary paclitaxel DCBs, or the silver or Eluvia stents. We can see that regarding the primary patency, there weren't any significant differences. However, stents had a numerically higher primary patency, as well as overall survival. However, limb salvage and freedom from TLR, which represent the most important endpoints in peripheral artery disease, were numerically higher in the DCB group. And finally, last month, a study from South Korea was published in JAHA regarding the use of imaging in peripheral artery disease. This is another sensitive topic because everybody recommends using intravascular imaging in coronary artery disease. However, most of the studies didn't show any improvement in overall outcomes when using it in peripheral artery disease. As a result, in our center, we use it in 5–10% of the cases, very, very rare, and almost every time we have a restenosis, but in new lesion, we almost never use it. And it's probably the same in every center. So as South Koreans use a lot of imaging, they conducted this investigator multi-center randomized single-blinded study, including 237 patients, which were randomized into an IVUS guidance group and an angiography guidance group. After 24 months, they followed the clinical efficacy outcomes, including freedom from TLR and sustained clinical and hemodynamic improvements, as well as freedom from major amputation. As you can see here, the use of IVUS in this type of lesions, in femoral-popliteal lesions, were associated with a lower rate of target lesion revascularization at 24 months follow-up. So maybe using it more often would improve the outcomes. However, bigger studies are needed, and maybe this study was done only on femoral popliteal lesion. Usually the study is included also below the knee. Probably it helps in the bigger vessels, I don't know, but in this study, the freedom from TLR, from clinically driven TLR, was significantly higher in the IVOS guidance group. Also, the time to the first clinically driven TLR was a lot prolonged when IBUS was used. Thank you for your attention.
Thank you, Leo, for the presentation. I missed like 2 or 4 minutes, and I don't know if you had a chance of presenting the SWID-PAD 1 and 2 trials.
No, which one?
SWID-PAD 1 and 2. They have been presented at DSC.
No, I've read it, but I didn't have full access to the SWID-PAD 1, so
yeah, you have to ask because it's free. It's on the Lancet. It's free, and Irfan has access to all of them. So you have to ask because you cannot do a presentation on the most recent improvements in DCB and without citing these 2 important trials. Another trial that you missed to say, to discuss about was the Sirona. Sirona is a comparison between Magic Touch Sirolimus and paclitaxel. And it's very important because you said Extosi is a registry, that's fine. And you said there is no direct comparison, whereas a direct comparison is there. And the data, the 1-year data have been presented like 1.5 years ago, and the 2-year data have been presented 2 months ago. It's very important. It's an important study. It's called Sirona. And then you missed to mention a long or mid to long-term follow-up. I think it's 2 years with a solution. It's an important study. I think 300 patients, and it's a very important study. So, I think that what you missed with this presentation is that you presented data with the impact. Nobody uses impact anymore. So impact deep, you presented a 5-year outcome, but the study, the 1-year outcome showing more amputation in the DCB was published in 2012. So that's a very old technology, and nobody uses that crystalline formulation in that version anymore for below the knee. And then there is the ACO-ART device. It's a Chinese device showing a good result. It's a microcrystalline formulation. So I think that you have to update this presentation with the really last 2 years data. We don't need, a study of 15 years ago. We need a 2-year data. How the technology is improved and how the clinical trials have improved for DCB, which are the limitations and which are the advantages.
Okay. So the Sirona and SWID-UP.
SWID-PAD 1, SWID-PAD 2, Sirona, the study of solution. I don't know if there is an acronym on that. Probably yes, but I don't mention that. And then the studies with the ACO-ART paclitaxel-coated balloons. They did a study for PEM-POP and a study for BTK. So if you can please update all of these, and maybe we can schedule another updated presentation in 1 or 2 months.
Okay, great.
And yeah, unfortunately, thank you, Iman, for the nice presentation and for taking care of this. There are not many fellows today. I would say there are not enough fellows today.
Yeah.
So we will discuss about this during the research meeting. I think it's going to be on Wednesday.
Yeah.
And so now I am canceling scientific activities to all of those fellows that recently did not show up during the lessons. So I kindly ask Sarah to send me the percentage of each fellow in terms of presence in the last 10 lessons. So give me the percentage, if you can do it by tomorrow, so that I can see, how can I adjust to the research.
Okay, sure. Thank you very much.
Yeah.
And coming back to Leo, and how Leo said, important things about DCBs. Is there any question from you guys?
Really, no questions from my side. Thank you, Leo, for the follow-up presentation. You did a good
So
job.
who is doing peripheral here? You, Iman, are you doing
I'm not
peripheral?
doing, no, I'm not doing peripheral.
And
I have
Jazim?
no, I have no experience in peripheral. Hopefully, next month I'm starting in a hospital where they practice peripheral. So, but I'm not really
Alright.
interested as well.
I'm not.
Huh?
The hospital practices it, but I don't.
Yeah.
Yeah.
You know, many, I would say majority of us is not doing peripheral now, but, you know, I'm not talking about peripheral like aortic or these things probably are really out of our interest, but DCB in peripheral is still one of our areas of expertise. So this is why I'm investing a lot in this type of lessons. And this is why this lesson from Leo and the next one are important for all of us.
Yes.
Yes, thank
Okay,
you,
that's fine. If
Dr.
there are
Yeah.
no other lessons, no
Doing
other
peripheral
questions
with
about
DCB
this,
helps you doing better coronary interventions with DCB. You learn
yeah,
to
you
be
learn a lot.
patient,
For peripheral,
you
you
learn
learn a
a
lot.
lot of tips from peripheral.
I agree with you.